how do you approach the idea of CIC in your patients with MS? So, I mean, we talk to a lot of patients with MS and we see sometimes some sort of borderline voiding dysfunction or a little bit of an elevated PVR. It's not a huge number where you're worried and you tell them they have to do CIC, but it's a bit high. And as you said, it can impact their capacity. They're not really keen to start CIC. It's a pretty big change to their quality of life when they have to start catheterizing to void. What are sort of your triggers for when you think someone should start on CIC in the MS population?
That's a good question. I wouldn't make it on a pure post-void residual volume number, because that is really, you have to see it in reference to the maximum capacity of the patient. So if somebody has a total volume of 500 and can use it in his daily life and has a residual volume of only 50, then it's 1/10, and he wouldn't be bothered by that, except he has any complications like recurrent urinary tract infections that could be associated with the residual volume, and that would be a trigger to start catheterization. But also pain could be an issue, and because many patients believe if urine is coming out, then the bladder is working fine. They're not considering that it is also important how it is coming out. So it needs to be a more or less physiological micturition where the bladder is not fighting too much against a certain subvesical resistance, either from the bladder neck or the sphincter or even the prostate. So this needs to be considered. And if that is the case, and many patients can develop a kind of pain symptoms over time because the bladder is like squeezing out, and it's not a physiological mechanism anymore, then it can be better to switch to intermittent self-catheterization. And then, of course, the patient has to have some patience until the symptoms resolve. But I have seen many patients that do better with that, and then they happily accept the self-catheterization because they are having less pain symptoms. They have less time on the toilet and more control about emptying the bladder. So that's an important issue. You of course, you get the patient best if you can show him that the self-catheterization is reducing his symptoms. For instance, we have also MS patients that have actually very large volumes where detrusor overactivity kicks in very late. Let's say it starts at 500 and the patient has a capacity of 600 whatsoever. Then he may even not need to take antimuscarinics, but he's just catheterizing before, and then he has a nice capacity that he can utilize throughout the day. And then self-catheterization is the only treatment they need to do, because some MS patients have really difficulties with antimuscarinics.
Yeah, and I mean, I think that's one of the reasons why a lot of patients do avoid those medications. And that kind of leads to my last question I was going to ask you, Ulrich. So with MS patients, I find that a lot of them do very well on intravesical Botox or onabotulinum toxin. But my concern always has been, if they're not catheterizing, if I put them into retention and they need to catheterize, then that's sometimes not something they're always happy with, right? So I've always struggled with trying to find any predictors of retention with urodynamics. And I mean, I know there's not a lot of great studies out there that have proven anything, but in patients with MS, is there anything you look at as kind of a trigger in the urodynamic study to say, this patient might end up on CIC if I use onabotulinum toxin?
Yeah, there's no definite number that I can say, detrusor overactivity is that high, or even if there is a certain detrusor underactivity. Certainly, if there's the combination of detrusor underactivity and detrusor sphincter dyssynergia, then there's a high probability that those patients need a CIC. And of course, the residual volume. It's more a combination of things. So residual volume, signs of DSD and detrusor underactivity. These are the three components. If there's one or even two or more of those three, then there's a high risk of intermittent self-catheterization. But even if you don't see any of those, then there is no guarantee that they don't need to catheterize. Maybe if you start with a low dose of botulinum toxin with 100, you may be it's maybe not necessary to categorize, but it really depends on the symptoms the patient has. Because if you inject Botox and the patient reports, I don't feel any effect, it may be because you increased his volume, but you also increased his residual volume. So this needs to be checked.